by international bodies on how you should apply the right to health, this panel is going to say, what is the role of civil society in advocating for and trying to turn the right to health into a practical reality for all communities? So I'm going to invite members of the panel to come up, and we're going to do a bit of magic, add another chair as we're doing that. So I'd like to invite, first of all, Raymond Gemen, who's the head of policy for EPHA, to come and join me. Then Denis Onyango, the director for the Africa Advocacy Foundation. Fatima, Awil, the Advocacy and Policy Officer for Mental Health Europe. And Jacqueline Bowman-Busato, who's the Head of Policy for the European Association for the Study of Obesity. So please, all of you come up and join me. And our challenge for this panel is to take that very dense set of paperwork, international treaties at international level, and see what's the role of civil society in understanding this, interpreting it, and monitoring it, and raising awareness? How do we use these tools at our disposal to try and push governments at national, local, or even European level to go where they may not voluntarily wish to go? So that's our big challenge. And I'm going to start by you, Raymond. Can I give you the floor? And I'd like you to sort of, particularly, you're going to tell us a little bit about the DisQo stakeholder network and your joint statement that we heard from Stefan. It caused a little bit of a buzz around the virtual coffee meetings in the Commission. So let's hear about it. And we have one microphone that should be up. I seem to have got both microphones. There you go.
Yes, thank you very much, Thompson. Is it working? Doesn't seem to. Button is green.
Right.
Hello?
Pushed up.
It's pushed up. People, technical people. I use first one. This is working. Yeah, okay, thank you very much, Thompson. I would actually like to start my short intervention by giving some thanks. So to say thank you, and I'm really, really grateful to all the speakers who have accepted our invitation to share their expertise and experience with us today, but also you in the room and the people online for engaging, for asking your questions. It has been very, very insightful. But thirdly, and importantly, I'm super grateful for all the inspiring people and organizations, and some of them are here on the left, on my left, that since we embarked on this journey, we had the pleasure of collaborating with and getting inspiration from. And for EPHA, as public health NGO, this journey started about 1.5 years ago, where together with our members, we were prioritizing our topics for our work on health equity. And not only did we identify discrimination as a topic of common interest, but also that no other, and we just spoke about it, no other European public health organization was actually specifically addressing it. And then seeing that Europe's vision for a healthier European Union, in other words, the EPHA Health Program that was adopted as a response to the COVID-19 pandemic, which, by the way, could not have had a more discriminatory impact on society, did not mention the words racism or discrimination explicitly. We knew that we were indeed on the right journey. Yes, it mentions health inequalities, as was mentioned before, but it was not mentioned how we would like to see racism and discrimination being addressed and being included in health policy. So we were going on the right journey. One of the first concrete actions that we took, we just spoke about it, and we are thankful for DG Santé for facilitating this, is to apply for a so-called thematic network. This is an annual cycle. It involves the organization of webinars, which are supported by and brought to life via the EU health policy platform. And it also concerns, or it involves the development of a joint statement. Long story short, we decided to focus on racism and discrimination. Again, credits for DG Santé for selecting the proposal. We used the EU health policy or the EU anti-racism action plan, and also the evidence that Abby this morning laid out for us that they so thoroughly put together with the Lancet Committee as our building blocks. We brought together people, I would like to say people and organizations who work across sectors, who indeed recognize that being discriminated on the basis of race, skin color, ethnicity, but also disability, migration status, etc., is indeed harmful for health, and they wanted to take an active stance against it. We gave the network a catchy name, DisQo, which stands for Anti-Discrimination and Health Equity. The network has currently 73 supporters. We have organized a number of webinars on topics identified by the network as key, as important. And we developed and presented to DG Sante our joint statement, which identifies 5 key priority areas for action. And I will briefly mention them. They are not, as Abby mentioned this morning, what did she say? I forgot. They are not groundbreaking. They will sound very familiar to you, especially after this morning's conversation. But I will briefly mention them. The first one is recognition. So this is the recognition. It starts with recognition of racism and discrimination as fundamental determinants of health across sectors, across levels of government, and within the EU health framework, we are calling for this recognition in EU for Health annual work plans and calls for project proposals. The second one is about people and about the meaningful involvement of people. The WHO has identified social participation as one of the 4 drivers of health equity. So it's really about involving the people in the development of policies from the conceptual phase all the way to the monitoring and evaluation policies. The third one is language, also mentioned today. So this, on the one hand, is alignment of definition. So what is the definition of anti-racism, for example, or what is the definition of equity? We hear about inequalities and we talk about inequities, disparities, but what do these really mean? And these are really key to have meaningful and constructive conversations. So this is also about respectful language, and this is also about, and that's what we're trying to do here today. And I think I have heard people sharing quite personal things to create this safe space for dialogue. The fourth one, I'll be very short about it, is equity data or health or equality data, sorry. Yes, it's complex, but we also hear it is very simple. If we can't measure it, we can't fix it, and we need to crack this nut. The fifth and final one is the need to break down silos. And this event is actually an attempt to do so, to bring the areas of public health and human rights together. And we cannot do this alone. And in the run-up to this event today, we had many meetings with Mila, and especially the first meetings, I had to listen very attentively because she speaks a language that I'm not speaking. She's aware of policy tools that I'm not familiar with. So I think it's really important that we bring those silos together. I'm going to stop it here. On your table, there are some cards that are linking to the website of this of the webinars and of the joint statement in case you're interested. And I look forward to hear from the others.
Thank you. I think we'll keep moving across the panel and then see how much time we have to exchange. Denis, let me invite you in. What I want to hear from you is, what is the specific experience of different marginalized groups? Particularly, maybe you could touch on this issue of unconscious bias and cultural competence. We heard this morning from Hans from Belgium about intercultural mediators, etc. Can you open up this package for us so we understand it?
Thank you. Okay. Hello, everyone. It's a privilege to be here. Thank you very much. And thanks, Tamsin, for the question. First of all, I would just like to start by saying that racism can be very exhausting. And if you have experiences of it each and every day of your life, sometimes you just give up and you become immune to it. So for a lot of people we work with who we're supporting, they have had experienced so much racism that sometimes they lack the will to be able to stand up and share those experiences or ask for better. So in terms of unconscious biases, I work in HIV, mainly with migrant communities across Europe. And I can probably use one example to illustrate this particular comment, which probably this professional did not intend to have the effects it had, but it ended up defining somebody's life for a long time. So there's a lady from Zimbabwe who was living with HIV. She had been initiated on treatment, and then she wasn't having a very good experience with this treatment. So she went back to the clinic and to see if it could be changed. And the nurse who was in charge, the HIV nurse, said this. She said, I think you should be grateful that you have this treatment, because if you're in Africa, you probably will not have it. And so this really, even though they were able to switch at that time and give her something else, she ended up still having a lot of problems with the second medication. And she stayed for around 6 years with very, very bad side effects, which compromised her life. And by the time, this was brought to, to the attention of healthcare professionals, it had really impacted seriously on her kidney health, and she was having multiple long-term conditions associated with HIV. So that's just one example. And I might not, I'm not saying that this particular healthcare professional meant harm, because they're meant to care for people, but such comments normally are a big problem. So what we see in the community is that when we work at the community level, sometimes it's much easier to define the problem and to be able to look at it and try and call for accountability. But what we see, of course, at policy level is that some of those lived experiences do not automatically translate to changes. And this is the question we ask ourselves, because we become so helpless that you wonder whether your experiences are going to be able to make any change at all. I mean, as I said before, it's much more difficult when you see leadership. So, for example, we're seeing the experience of migrants in Europe at the moment, where African migrants are not welcome in Europe, where there are blatant racism, where they're being treated very, very differently from other migrants from Europe. And so you wonder, whether your experiences are going to make a difference at all, whether when you share about your experiences of racism, it's going to change anything at all. So I think that's just one thing that we need to look at how we can become culturally competent. And cultural competence is not just about knowing somebody's culture, it's about placing yourself in that person's position, because behind each of this is an individual who is dealing with a lot of issues. And when you have a system where we have very historical injustices. We've got a lot of political and economic, reasons for some of these, kind of systems we see which are really discriminating against certain communities. It's quite difficult for people to change when they exist within systems that are prejudiced, that are, discriminating, that are not including people. And therefore, I think that we need to be able to educate ourselves about the challenges, about experiences of people, because when you remove yourself from the high level and bring yourself back to the ground and really relate to that person at that level, it becomes much easier for you to understand what experiences they're going through. And I think that's what we are lacking. And even as a sector, the civil society, I think lived experiences are very important. We should try and try and listen to people and see, because something that you may think is not an issue might be determining somebody's ability to be able to realize good health outcomes. So I think that's really important.
Thank you very much, Denis. Fatima, let me invite you to bring in your experience and the experience of your network, particularly in the area of mental health. We heard earlier today about the importance of intersectionality, that people's experience may be related to multiple aspects of their identity, and how it is both cumulative and additional for experience. So maybe you could share the experience of your network, looking particularly about that link between racism and mental health.
Yes, absolutely, I can do. And good afternoon, everyone. I'm really happy to be here. So thank you so much for the invitation. In case you aren't so familiar with our network, I am the Policy and Knowledge Officer at Mental Health Europe, which is an umbrella European organization. And we have over 70 members in over 30 European countries. And our membership is really diverse and ranges from all sorts of experts, from academics to persons with lived or living experience, to service providers, and much more. Hello, Matthew. And so within our organization, what we really do is bring together the expertise from our membership to shape policy and legislative processes so that mental health is really prioritized across Europe. And I'm really happy to hear that mental health has been incorporated into conversations that we've been having already today, because indeed mental health and racism is interlinked in terms of when we look at forms of oppression and how they impact different groups. And so we're really happy to be part of the DisQo network, which brings together different stakeholders that want to work towards anti-racism and anti-discrimination, and how actually we can implement that in the work that we do within our organizations, and actually practically the steps that we take in terms of our activities. And so one thing I really want to highlight is that mental health can be understood as an integral part of our life in terms of the relationships that we have, in terms of the way that we cope with stresses in life, and how we are able to really navigate in a system that not always is practically set up to support us. So mental health lies between in a continuum. It's not a topic which is not understood, but over the years it's been receiving more and more attention, which is great to see. And what we highlight is that mental health can really lie between the continuum of good mental health all the way to psychosocial disabilities. And so the support that's provided needs to be flexible and to really understand that. And racism and discrimination affects our mental health, but also racism and discrimination impacts the services and the support services that are in place to help those that are experiencing this with lived and living experience. Because as we know, we haven't reached the anti-racist society, and so we have to recognize that that is reflected in the services and in every institution that we see. So I'm happy to hear that intersectionality has been brought up today. And intersectionality really is a way of understanding social relations and examining intersecting forms of discrimination. And this also means that we must acknowledge the social systems that are complicated, as well as our identities. And this means looking at our different identities and the forms of oppression that we experience, and how that actually can be understood better and shaped to form better support systems in place. Because we look at mental health as promoting mental health, preventing mental health problems, but also ensuring that those that are already experiencing mental health problems receive the correct support that is tailored towards their needs. And so without realizing this, the support that racialized communities and those that are facing discrimination in whichever form it takes, they won't ever receive the correct approach and the right support. And so this problem will continue to take place over time. And in terms of the approach that we take, we promote a psychosocial approach to mental health, which is in line with the UN Convention on the Rights of Persons with Disabilities. And this requires looking at the social determinants of health, of mental health, and taking that into consideration when providing the support that an individual needs and every approach as well. So for example, someone who is facing racism in the workplace, support and therapy may help them, not to deny that, but we actually have to tackle the root problem. We have to address the work environment, which is oppressive. And without doing so, the problem will continue. So we have to really look at things from a structural level. And unfortunately, what we usually see is responsibility is placed on the individual rather than looking at it from a systemic perspective. And that's why I think it's really important that organizations like ourselves continuously work towards anti-racism, and that we work with experts that work on mental health, whether it's directly or indirectly, to push for this. And I think being part of networks like this is very important for working towards an anti-racist society. So I'll stop here. Thank you so much.
Thank you very much, Fatima. Let me pass over to you, Jackie, because you were part of the DisQo stakeholder network, but you also have been doing excellent work around a citizens' right charter to highlight the importance of operationalizing the right to health and the link to other issues. So please tell us about it.
Yeah, thank you. It's actually been an absolute pleasure to be here today, because as some people in the room know, my educational background is actually public international law. So I've been really enjoying the conversation. I'm also, clearly, I've been in healthcare policy since 2000. So to actually see the different communities in the room has been fantastic. Now, Raymond actually reminded me indeed of that day 2 years ago when he called me and said, Jacqueline, we need some help. And why? Because I've been sitting there for, I don't know, over a decade, actually wishing this day to happen. As somebody who is, 23 Guyanese people in Belgium, Black woman, regardless of socioeconomic status, I have been struggling to get healthcare. So with that, I'm now going to go into the professional side of this, which is that Actually, as head of policy at EASO, we represent 20,000 plus obesitologists. So that's healthcare professionals, public health professionals, researchers, and students, all specialized in from prevention through to treatment and management of obesity. So malfunctioning adipose tissue, long story short. Why is that important? Why is DisQo important for us? Well, actually, we have a legal obligation under the law to provide state-of-the-art health service delivery. We have an obligation under the law to be educated and competent in order to provide that. And that includes non-white people. I mean, let's be clear. So the official reason that I'm part of DisQo is actually to make sure that my 20,000 plus strong community, we can do our jobs. I mean, literally, this is not a do the right thing issue. This is, we have a legal obligation. And that's actually my second point, that how do we know that we have this legal obligation? Because goodness knows, and I'm keeping that on time, goodness knows that nobody talks about it. Because in the world of obesity and generally in the world of health, it's all very much a case of let's do the right thing. You know, we really care about patients. We really care about, in the case of obesity, children. You know, we know all of this. And then it's, well, eat less, move more. Whereas this morning, we've heard very clearly the biological links between stress, cortisol, the biological triggers which lead to malfunctioning adipose tissue, depression, inflammation, all the things that are actually related to the biology of obesity. We need to be able to do our jobs. So I have two hats. So on the one hand, I'm there for Raymond, absolutely, and EPHA. On the other, because of my own personal lived experience as somebody living with obesity and endocrine obesity, talk to me about it afterwards, because there are about 6 for adults, or different causes, and lots of the mental health and neurological and neurodevelopmental disorders related to all of that. So I'm cheering you along the way. Actually, I have a vested interest in making sure that I have access to proper continuity of treatment and care. And because of my background, I said, but this is not happening in Belgium. I mean, there is no system for any of this. So I started looking into it, and it ended up being a co-founder of a foundation for the rights, the legal rights of citizens with obesity, which started off in Belgium, but hey, we're now international, what can I say? And then we actually collaborated with VUB, so the Free University of Brussels and KU Leuven, to do some proper research that nobody could dispute, that could actually be peer-reviewed, therefore cited as part of policy documents, as well as move into policy and practice, to look at, A, what is the situation in Belgium for access to healthcare? Let's just say it's very random in terms of citizens' rights. Do we have legal rights? Yes. Actually, talking again about the international norms which came into EU, the cross-border healthcare directive, the qualifications, equivalence legislation as well. In Belgium, we've had patient rights legislation since 2002, and that includes everybody in this room. It's not because you've got obesity or you haven't. If you're a health systems user, for whatever reason, those rights apply to you. So once we actually work that one out, we could then look through the lens of, well, how fit for purpose is all of this for people living with obesity? Very short answer, it's not. So through focus groups, through surveys, sorry, that's all we can do, but you know, we managed to get there, as well with some desk research, PhD students, and all the rest of it. We actually have a Citizens' Rights Charter, which has been presented to our Federal Minister, Frank van den Broeke, and all of these things. But the gist of it is that under the different elements of patient rights legislation, we're then able to actually out and out lobby and advocate at policy as well as practical level to say, how do we achieve that health service delivery? Because at the end of the day, those rights are there. that, for those of you who read Belgian news, you're seeing that they're being literally just ignored left, right, and center. So for us, DisQo has been fantastic, inspirational from a health professional's perspective. We need to do our job. And also, to be frank, has inspired me in my volunteer life in Belgium to say, we have legal rights. Let's move from human rights, which quite frankly, countries love to find an excuse not to implement them, but to actually say, these are the international norms, which if we start being a bit creative, we can actually see that they are already embedded legally. What are we going to do to get to them?
Excellent. Thank you very much. And it was a really interesting overview of the different approaches and what you're doing. I'm now going to open it up for questions or comments from the floor. And if you, Jacqueline, if you can pass the microphone to Thomas. I think we've already got a comment or a question online from somebody who'd like to talk to the panel. So Thomas, what have we got?
Yeah. So we have one question from the Slido, actually, from the Q&A there, and it's related to the discussion, or at least the opening statements that have already taken place. It's basically, and it relates also to the presentation that Mila gave, but it's about, do member states actually need the work of civil society organizations to be able to comply with their duty to protect health? So what's the role of civil society in that sense?
Okay. Who on the panel would like to answer on that? Do members... I was figuring you'd want to answer.
I know, gosh, once I started. Simple answer, yes, because people don't seem to understand that health professionals are civil society. People of lived experience are civil society because we're organized. So, and actually, again, under patient rights legislation, one of the points, which I think actually was mentioned, is that there is a legal obligation to involve civil society in the law making. Another thing that's conveniently forgotten. So it's our legal right to, we need to be doing it from whichever stakeholder group we're coming from.
Thank you. Raymond, you were also nodding. I think you wanted to add in? Go ahead.
It's kind of repeating what Jacqueline just said, but I mentioned the social participation as one of the drivers of health equity. I mentioned before, there are 4 of these drivers, and the first and foremost one is accountability. And if someone needs to hold power to account, I think it's the civil society.
Thank you. Fatima.
Thank you so much. I definitely agree with what you both said. We think also as part of involving civil society, we can go through a process of co-creation where we connect civil society and experts with those with lived experience and the experts on the ground. So, for example, when it comes to mental health, community-based services are monumental for providing the correct support. So without involving the actors on the ground at all levels, actually, through at an equal basis, we can then come together to actually put forward policies that reflect the needs on the ground and actually put together accountability frameworks that actually are practical and can be utilized, as well as policies that are implemented on the ground. So all of this is critical for a process that is functioning well, and therefore we reach a society which is human rights based as well.
Thank you. Does anyone in the room have a question or comment you'd like to make to our panelists? Do you want to go ahead and speak, and hopefully the green microphone will capture you?
Well, I can try, but I don't know if everyone can hear me.
Yep.
Okay, so thank you very much for this intervention, and thank you very much for the panel. I have a little question. So we've been talking a lot about high-level intervention in terms of health. So we're speaking a lot about doctors and so on. And I was wondering, could this also include low-level intervention? For instance, refugees assistance, lawyers and so on are not very trained into how to speak to refugees about traumas, for instance, and mental health. And so there could be questions that they could address to refugees that would be triggers and that would actually trigger their mental health sensitivities and so on. So I was wondering, under this right to health, can we not also have a right to health, but on the low level of intervention, and therefore we've been talking about including civil society, but what about other stakeholders, let's say, other lawyers? Shouldn't they be able to also have a trainee on how to speak and how to implement this right to health?
Thank you. Just tell us who you are.
Clarisse Fagar, and I'm a global mental health student.
Excellent, thank you. Okay, there's a comment there. Dennis, you've taken the microphone. I think you're ready to go. Can I just see a few more hands, people who might want to intervene? A few more on this side. Okay, Denis, would you like to take that?
Thanks for such a good question. Yeah, I think from my own experience, I agree with you that we are the experts as community organizations or civil society. And I think that, you know, normally you wouldn't see any initiatives to, for example, build competency coming from the state or statutory sources. So what we've done, for example, we recognized we're working with women who have experienced female genital mutilation and are experiencing at risk or have experienced other harmful cultural practices. And initially this was being commissioned as a domestic violence issue, as a violence against women and girls issue. And they could not see the related mental health and the trauma that FGM causes, for example. So we had to advocate to ensure that, you know, there was cross-border working in terms of, you know, the statutory services around domestic violence and also health, so that health services could specifically be able to recognize this as an issue. So what we did was to provide cultural competence training for educational, social care and health professionals so that they could work effectively with families. So I think that's one of the ways to build, you know, the expertise of some of these frontline professionals, not just the education and health and social care, but also, as you say, legal professions and other you know, professionals who interface with families.
Very quickly. So I could interchange the word obesity with race discrimination, access to health. I mean, so many synergies. Very long story short, what we had to do within the EASO environment was actually to create a taxonomy. So a working lexicon to be able to have very precise and very accurate language that, quite frankly, wasn't discriminatory as on the basis of size or health status, so that we could actually match it to the language that people are comfortable with, so the NCD language. And that goes out to everybody from policymakers down to the ambulance person, quite frankly, that needs to take you into the hospital, because health service delivery is not doctors or dentists or alone, it's everybody that has an impact on your health outcome.
Thank you. And just before I come to the floor, Fatima, I don't know if you want to add in on anything, if you've got any additional input you can give around the criminal justice system, because in the huge issues of mental health and the criminal justice area, you've got a disproportionately large numbers of racialized populations within the criminal justice area. Is this anything you can add on to?
Yes, and I think it really does apply to different professionals as well as in the justice system. Training is very, very important, not just a one-off, but continuous training, because our environment does change and our circumstances are different. So they need to be equipped with the right resources and information. And also, to go a bit further, we also need to look at the curricula as well, because often these topics aren't adequately integrated. And so the first time a professional will be facing these specific circumstances and will be in practice on the ground. And not to say that it's too late, but we could do better to shape our education, to shape our training, so that it's reflective of the needs on the ground. And also in terms of the actors that do provide that training, I think it should also be an opportunity for communities that are most impacted that are able to lead it. So we often see community-based organizations are able to provide training, but they're not adequately funded, or they're not involved as part of this process. So we do need to see the right actors on the ground also providing that training.
Thank you. Lady at the back who wanted to speak, and then I'll come to you, Mila. Yes, please go ahead. Let's see if the big green microphone picks up your voice.
Yes, as you remind, I'm on the neurodiversity discrimination, but I wanted already to answer to Mila about anti-racism. It's not connected directly, even if some connection can exist. But when you speak about a low-level civil society and you speak about health connected to work, I think there's a very large work also to do with all the leaders and the policymakers, the stakeholders in companies because they can't really explain also really they need a network to speak what are their trouble, their problems with their policy inside the company, because mainly it's a question. It's not only question of racism. Mm-hmm. The problem can be somewhere else, yeah. But they need to feel free to speak, and it's good to connect a network with all these stakeholders to have a round table to speak without any fear about what they experience. I will tell you just one example, which is very simple. In my past life, I did some recruitment myself, and I had to recruit for an old-fashioned insurance company. I knew that the human resource manager never recruit somebody else than a white person. I knew it. I had 3 applicants. One was a black person, and I knew he was the best one. If I tended to be pushing this manager, it wouldn't have worked. So I think really it has to do with the training, with the information, with education. At the end of the day, he has recruited that man, because the way I've presented, without being angry to him or making him culprit of anything, I just described the 3 applicants. Mm-hmm. Of course, I have the question that normally I shouldn't say, but which is and which make a lot of people here angry. The question was, oh, what kind of black? Is it coffee with milk? No. Yes, it was like that. But this man, I kept on speaking with him, trying to educate, because I felt it's just because he's not used to. He has to he was old-fashioned, let's put it like that. And then I just naturally described that he was white, black, he had studied that and that. And then at the end of the day, he accepted to receive him as the other 2 applicants, and he has recruited him. So it was the first non-white person in his team. But just this experience is very basic, and I would say it's an example among others. But I think because I've heard a lot of human resources managers, there are a lot of networks between them, but this topic is like a taboo. They can't speak about how they feel. Of course, there are laws. They have to not to show any discrimination, of course. But it's even better if you make a training or education and a free talk. They can speak freely about how they want to make their job and how they need to be helped in their job. Then the civil society, the low level, will work better, I think.
Mm-hmm. Thank you.
It's a topic to develop, I think.
Mila, you wanted to come in? And I know we've got a couple of other questions online, so.
Definitely, I will try to make it very fast and mainly towards probably Fatima and Denis and all people who are experts in mental health. And indeed, the topic of education, sensibilization, training, changing mental set and bias and prejudice is key. It will take probably very long time, and indeed we have to start working very actively in this area. For the mental health professionals, I wanted to ask a question, and probably this is a request for support and guidance, and if you can keep on collaborating as much as possible on this topic. One very concerning fact that I have noted, but I'm not an expert on these topics, is in the FRA reports, in the FRA study of being Black in Europe, the previous one and the most recent one, despite the high level, I will not give numbers because incidents between countries are very different, no, between Finland and Greece and so on. But let's say from the high percentage of people who have experienced or report to have experienced racist treatment, the reasons for not reporting, they vary, because I don't trust in the system, because it's difficult, because I don't know. But there are two reasons that I find very concerning, and this is my question to those who are professionals in mental health issues. It's minimizing the problem. You said it's like when you're so much a victim of something, you first get used to it and then you become immune to it, which is not necessarily a good adaptation strategy or a good way towards healing. Okay, the answers of people for not reporting include, well, at the end of the day, it was not so bad. I minimized the experience, and then I can deal with it by myself. What is your feeling on this? My feeling is that these are topics on which we have to put special focus, and especially that probably thanks to COVID, the topic of mental health is every time more and more on the table being dealt with.
I'm happy to take it. I know you also want to add on. I think that's a really great point that you bring up, and I'd love to talk about it from the perspective of the work that we're doing at MHE, but also my personal experience as a Black Muslim woman in Europe. I would say, first of all, the concerns that you shared is very much reflective of the problem that we have, where when we look at mental health and tackling mental health, it's still not being addressed at a structural level. And so the solutions that are often provided is placing the responsibility at an individual level. And so for a Black person in Europe, and I can speak from my experience, you grow up feeling that because the society and support mechanisms aren't adapted to your needs, looking at, when we look at racism, it's at a structural level, so it's really embedded to the very fabric of society, in all industries, in all systems. And so that leaves the individual to often be failed time and time again from a very young age, where they're not able to find adequate support. Often they're gaslit when they highlight situations, even in terms of employment, and feeling that you're being discriminated against, but you don't have solid evidence. All of this has implications in terms of the person feeling that, they're minimizing maybe personally their situation as a coping mechanism, or they feel that, there's no point actually reaching out because there are long waiting lists, services aren't accessible, and they're not tailored to your needs. Or even in terms of things such as language barrier, finding a support professional which is able to be culturally sensitive, to understand your perspective, and then provide solutions that look and center the individual, look at their environment, and therefore tackle it from that perspective, rather than saying, go and take a walk or connect with nature, which is also important, but we have to look at it from that perspective. And I appreciate you sharing. And as MHE, we're hoping to have to work on actually racism and mental health next year, and really elevate our work through an intersectional perspective.
Thank you. I'm just going to ask Thomas to share the two inputs we've had online, and then panel, you can have 1 minute each to just give your concluding thoughts. Thomas,
okay, we have two comments. We'll have to see how we deal with that time-wise. One question is directly to Fatima, actually, related still to the topic of employment. Luciana Gomez online is asking if there are actually some examples of anti-racist interventions in the workplace that she could share, something concrete. And then we also have a question from Margarita Spasova to all the panelists, if they have ideas of good practices for engaging citizens in participatory progresses for improving access to health on the local level. Might be a good way to end the panel on too. I don't know, but I'll leave the rest with you, Thompson. But those are the two questions we had from online. Thank you.
Thank you. I think that is a great question to ask each of our panelists. Let's focus in on a good point. Have you got an example to share that you think this is what good looks like? This is what good service provision, good cultural appropriation would look like. How do we, give a tick to say, that's the kind of standard we're aiming at? Now, Jackie, you were nodding at that, so I'm going to start with you.
Yeah, it's actually my volunteer work. So the charter, we wanted to make sure that there was actually uptake, because charters are a dime a dozen. And so we literally are developing a toolkit and hopefully piloting how can I say, know your system, know how to get around the system using your legal rights to access to healthcare. And we want to be able to do that not only for people with obesity, but actually we're looking at oncology as well, and preferably people from minoritized, racialized communities. So directly, next time you're going to see your medical professional, you will have your list and you will know what your rights are and how to assert them.
Thank you. Fatima.
Yes, in employment, actually, as an organization, we do training at mental health at work. And just to give a quick example, one aspect is training. So actually inviting organizations that are experts on the topic to open up discussions. We've talked about earlier, I was hearing about safe spaces and actually changing our environment so we're able to have these open discussions and therefore work towards a solution. For example, internal policies that are mental health, but also anti-racist as well, because they go hand in hand. So I would give this as an example, but I'm aware of time, so happy to talk further if anyone wants later on.
Thank you.
Yeah, very quickly. So there are two examples. One of them is that we've been working with the National Health Research in the UK to include our communities in research so that we can be able to inform policies and procedures. The second one is at EU level, we're working with key populations. So we are working on an initiative called Nobody Left Outside Initiative. It's nobodyleftout.eu. If you go there, you'll find a health design checklist, which has been made for policymakers and commissioners and service providers so that they can have services that are tailored to the needs of key populations.
I want to say actually something very similar to Fatima, and I think that is something that is not necessarily a policy, but I think that is something that each and everyone can take home and can do, is to have conversations around these topics in a very informal but respectful way. And in this way, we can create and nurture these conversations, to expand and get larger until we get indeed those policies. Because ultimately, there needs to be policies, organizational policies, that safeguard these topics. But I think it starts with conversations with people.
Excellent. So can we say a warm thank you to this panel for sharing their expertise and ideas? We're going to reward your participation with a